Dear colleagues and friends, welcome everybody. We are very proud to see almost 350 registrations to this virtual side event from all around the world. And you can start your chat with us. Make question and you will receive answer. My name is Massimo Barra. I am here on behalf of the International Federation of Red Cross and the Red Crescent that is hosting this debate. 1 year ago, when we launched the Rome Consensus 2.0, I clearly stated that this initiative aims to improve the life conditions of those who make a problematic use of drugs and suffer because of the harmful consequences of their disease. If you look at the Rome Consensus Manifesto, we are not asking the impossible. We are only suggesting a minimum standard that national governments and local services have to follow. First of all, we are here to clarify a crucial issue concerning the international debate that shifted for so long the attention from the concrete solutions available to improve health conditions for people with drug disorder to the sterile debates between the supporters of prevention or of harm reduction or of treatment, as they were belonging to three different parties fighting each others. The debate has largely been characterized by the division between harm reduction support and their opponent. In some cases, it remains only a lexical problem, despite its concrete implementation. Sometimes the term harm reduction is avoided, even if applied. From the plenary of this session, we are happy to hear that finally some member states clearly use the word harm reduction in its official speech, as they never did before. And this for us is an outcome. The real shocking issue I would raise is that only 1 out of 8 people with drug disorders have access to the treatment worldwide. This is the main political systemic problem to solve urgently. This is the real scandal. In 2021, it is clear to everyone how the response of many governments to drug health problem is still inadequate. The Red Cross and Red Crescent, together with all the supporters of the Rome Consensus 2.0, believe in the concept of the continuum of care, from prevention to treatment. A successful integrated system of care that guides and tracks patients over time through a comprehensive array of health services based on the strategy of meet and treat all people in need with no discrimination. The starting point of any treatment for people with drug disorders is to avoid the point of no return. And so it starts with harm reduction, to avoid irreparable harm to health and to keep the person alive and safe. Evidence and personal experience in the field show that therapy is a long path. The chance of success of the therapy is always proportional to the time spent under treatment. A good treatment program must be adapted to the motivation of the patient, tailored to the needs and will of the person, and not vice versa if you want to succeed. Above all, treatment should be available, accessible, sustainable, human, and supported by public authorities. Evidence shows that those who have access to non-violent and comprehensive treatment become less dangerous for themselves and for their family, and have a greater chance to quit from drugs and experiencing improvement in all the aspects of their life. In this regard, the best prevention is the therapy itself. The more people you treat, the less they can have a negative influence on their peers. Following the plenary debate of these days, we are confident that improving signals are coming from the international community. IFRC is ready to continue working together with member states and civil society to protect the lives of those in need. This is my speech, and now I'm delighted to welcome and introduce His Excellency Alessandro Cortese, the Ambassador of Italy at the UN in Vienna, who since last year showed interest and support to the Rome Consensus initiative and co-sponsored this event. Please, Ambassador, you have the floor. Thank you.
Thank you very much, Dr. Barra, firstly for your very inspiring opening statement, and also for giving me the floor. I'm really very pleased to attend this important event, important meeting, which, as you reminded, is co-sponsored by the Italian government. And I wish to thank the organizers, and in particular yourself, Dr. Barra, for the kind invitation. Let me first of all congratulate the promoters and partners of the Rome Consensus 2.0 for the success of this initiative. And again, you reminded it, I attended the successful launching event of the Rome Consensus 2.0 held on the margins of the last CND in March 2020. And I wish to also remember in a way how beautiful was the framework there. We were in the big conference room all together, chatting, which is a pity we cannot do it this time. Luckily, technology helps us, but I hope that the next event will be again live, and we will have the opportunity to also to interact, during the in the meeting room. And again, I'm very, very happy to see that so many organizations, stakeholders, and citizens have, in the meanwhile, in this last year, joined the initiative. I truly commend the passion as well as the compassionate spirit, forgive me the little wordplay, which guide the Rome Consensus 2.0 declaration, which is a real call to action to ensure that no one is left behind, and that treatment, care, and assistance are available and accessible to anyone in need. In a nutshell, it is an appeal to respect of the inherent dignity of all people affected by addiction. Too many of us have experienced the drama of seeing a friend or a relative falling prey to the self-destructing spiral of drug abuse. This should constantly remind us that more than anything else, the world drug problem is a social, humanitarian, and public health problem. The need to promote a health-centered approach to drug dependence is pressing. And this idea, thanks also to strong advocates such you, Dr. Barra, is very deeply rooted in Italy's drugs policy. As a matter of fact, in the Italian model, access to treatment is provided by the public service through a multidisciplinary approach, and wish to stress that there are around 570 drug dependence units, which provide free care to tens of thousands of drug users every year. And they are complemented by a vast network of hundreds of care and treatment centers, some less known, some best known, like Villa Marini in Rome, and therapeutic communities accredited to the public sector. The promotion of a health-centered approach to drugs rests on the recognition that drug dependence is a complex and multifactorial health disorder. Moving from this definition, which is universally agreed, it is clear that we should not, actually we must not, criminalize legally or socially people who use drugs. On the contrary, it is essential to overcome stigma and discrimination that often represent unsurmountable obstacles to the recovery and social reintegration of drug users. And I believe it is our duty, states, civil society, ordinary citizens, to promote more inclusive and less judgmental responses to the problem of drug dependence. In bringing together states, international organizations, civil society, and citizens, the Rome Consensus 2.0 offers an invaluable platform to gather support around these objectives. This is a high and noble mission, and I commend all those who are contributing to its realization. Thank you very much.
Thank you very much, Ambassador, for your kind words and for the participation. I also hope that next year, inshallah, we can meet again, all the family that is growing. Since last year, we have been always in contact, and people that did not know each other, now it's like a family. And I hope that after this meeting, the family will grow and we can arrive till the last mile, where drug problem is neglected or not considered for the reality. So thank you, Ambassador. It is very useful for us to feel your presence and to feel your encouraging words. And now I ask Giovanna Campello, head of UNODC Prevention, Treatment, Rehabilitation Section. You have the floor. Thank you, Giovanna.
Thank you, Massimo. Can you hear me?
Yes.
Thank you. Thank you, Massimo, and thank you to the government of Italy and the International Federation of the Red Cross and Red Crescent Societies and all of the stakeholders of the Rome Consensus 2.0 for organizing this panel around such an important conversation, and one that is sometimes more difficult than it needs to be, as Massimo was reminding us. And in my experience, stakeholders at the international level might look very divided sometimes by philosophy or language. But whatever you call the services for people who use drugs and people with drug use disorder, I think it is possible to build on the consensus that has been achieved in the international arena and that the ambassador just so eloquently described, and build national system of services that firstly provide unconditional support to people who use drugs and people with drug use disorders, whether or not they might need or might be motivating in starting a process of treatment and recovery, as you were reminding us, Massimo. And second, services that are there and ready with an open door if and when people who use drugs and people with drug use disorder become motivated to start such a process of treatment and recovery. And ever since member states agreed in 2009, they should reduce not only use and drug use disorders, but also drug-related health and social risk, UNODC has advocated to connect what our member states call services aimed at minimizing the adverse health and social consequences of drug use. And that, as you were mentioning, Massimo, at least some member states call harm reduction services. and connect them to services for the treatment of dependence and other drug use disorders in that integrated system that I just described. And INCB had recognized the value of such integration already in the 90s. Our latest attempt at promoting this vision are the UNODC WHO International Standards for the Treatment of Drug Use Disorders that we presented at CND last year. And the standards identify broad treatment outcomes that include the health of the individual, as well as the reduction and cessation of the use, and present the integrated and evidence-based system that is needed to achieve these outcomes. And I'm very, very grateful to the Rome Consensus for their great efforts in advocating unity, because I think the divisions harm, in first instance, people who use drugs and people with drug use disorders. Without take-home naloxone, needle syringe exchange, or methadone buprenorphine maintenance therapy, people die. Meanwhile, without psychosocial support, people whose life has been severely compromised by their drug use disorder will live, but will not thrive. And regardless of philosophy or language, there is more impact, more strength for everyone in unity, not in division. The strongest results for opioid substitution therapy have been obtained in combination with psychosocial support. And sometimes it doesn't need to be too much, but it does make a difference. On the other hand, let me take an example for what many may consider the frontier of services to minimize the adverse health and social consequences of drug use, supervised consumption sites. This example that I have in mind, the site is embedded in a treatment center offering a recovery-oriented continuum of care, much like Villa Maraini. And the data collected showed that of the people who use the supervised consumption site, many more than expected, after a while came forward and asked to be admitted in treatment and therapy. Finally, strength is in unity, in integration with a spirit of care and non-stigmatizing attitude, as our member states call it. And I would like to end with a quote from a participant in our take-home naloxone study in Ukraine and Central Asia, where we trained 14,000 people likely to witness an overdose, people using, first responders, and families, and we equipped them with naloxone. And one of the participants in the study reported, quote, "I used to think that everyone was just waiting for us all to die who needs these addicts. But this program showed no, someone needs us. Someone cares about how to save my life." End of quote. And I think this is the spirit that we need to, and we can engender in our system of services if only we pull all together. Thank you.
Thank you, Giovanna. You say some important things. I don't want to comment, not to lose time to the other speaker. You were also 20, 30 years ago in Vienna, and you are witness, and there is an evolution, and this evolution is very positive. So when we meet, we don't lose time, but we contribute to change things in better. So thank you very much. I will not comment each speaker, not to lose time. I will give the floor now to Ben Levenson, President and founder of the Levenson Foundation in the United States. It has been fundamental for the birth of the Rome Consensus. I remember the meeting foundation of the Rome Consensus. It was exciting. So thank you very much, and you have the floor.
Thank you so much, Dr. Barra. I really appreciate that. I also want to thank the Italian government, the ambassador, the International Federation, Via Maraini, and my fellow presenters, as well as my Rome Consensus family and guests. I was relieved to learn that I'm not the only one who senses we have entered into a special moment, a moment of opportunity in the history of drug policy. Certainly a moment with pain, rage, ideology, tribalism, sickness and death, but also great resolve, open-mindedness, humility, compassion, creativity, and last but not least, that uniquely human state of being hopeful. I have only a few minutes to share with you the context for why I am hopeful, why the principles in the Rome Consensus are relevant, timely, and vital to healing the divisions that for too long have blocked collaboration and pre-contemplative engagement. Why I believe this is a moment when one remarkable man's life's work intersects with its highest intended purpose and illuminates for all of us to see not just the worthiness and dignity drug users are inherently entitled to, and not only the values, the humanity, the radical love that Massimo has demonstrated for those he has served, but most importantly, those qualities and capabilities the Rome Consensus declares, and Massimo so clearly believes that we all are capable of embodying for all people everywhere who use drugs. I learned 25 years ago in my walk of recovery that it can be extremely dark before the dawn. Faced with so much change in how we have all lived our daily lives the last 15 months, the one fact that has become normalized in American life is an awareness that we are all living in the face of not one, but rather a constellation of crises, each of which, taken alone, is often deadly, but taken in concert, has proven lethal to even the strongest among us. By the end of 2020, the phenomenon originally referred to as the prescription opioid epidemic had claimed 450,000 lives, the majority of whom were, of course, Americans of color. This week, the CDC published fatal overdose data for the 12 months ending in September, showing an approximate 30% national increase to 81,000 overdoses in the year ending in September. Only 6 of those months were during COVID, so that metric will worsen. Unfortunately, the complexity only starts there. Experts in this audience know that the US is not in a prescription opioid epidemic after all. In fact, cocaine and methamphetamine-related overdoses exceeded those caused by prescribed opioids. Opioid prescribing among American physicians has been incrementally arrested, and the data suggests that now only about 6% are associated with the expression of OUD. I'd like to compare with our contaminated drug supply overdose crisis also the structural racial, gender, and health and social inequities that can't be overstated. One study listed that only 35 times, African Americans were 35 times less likely than whites to be prescribed buprenorphine. Resounding demands to reform American policing, criminal justice system, and reform our drug policies and the effect they have together on tens of millions of Americans who use drugs has registered in the highest offices in government with policymakers across the land in academia, medicine, and family. A fundamental shift is occurring. One US state said no more. Oregon effectively decriminalized possession and roundly rejected federal sentiment. Every drug policy reform initiative on the ballot last November passed with resounding success. The Biden-Harris priorities in the capable hands of dedicated career servants at ONDCP and beyond signal key changes. As we relocate drug use away from justice and punitive frameworks and into health and medically centered frames, we normalize and scale harm reduction, stand up low threshold treatment engagement, leverage peers, and develop integrated care using incremental improvements to drug user health and safety, and validate not only multi-pathwayed recovery, but also multi-destinational recovery. As we do that and we iterate on how to engage with and care for drug users, I hope we do more than look to the Rome Consensus for guidance. I hope that we do the hard work to formally recognize it domestically. Thank you so much for your hospitality, Dr. Barra. We appreciate.
Thank you very much, Ben, for your speech. Important, but also full of emotion and passion. Thank you very much. And now I give the floor to Judith Tkwaha, member of Kenya National Authority on Drug Abuse, to Nairobi. You have the floor.
Thank you very much, Dr. Massimo. I feel honored to be in this session today to discuss the involvement of government and CBOs in service provision for drug users. My name is Judith Wala. I am the Counseling and Rehabilitation Manager in NACADA. NACADA stands for the National Authority for the Campaign Against Alcohol and Drug Abuse. And NACADA is the national agency that is mandated with the responsibility to control and to oversee or regulate the rehabilitation facilities in the country. Among other responsibilities of NACADA is to provide public sensitization and campaign in regards to alcohol and drugs. Something that excites me is that the five years I have worked in NACADA, I have seen drug users and provision of services for drug users improve. Initially, we could not do MAT clinics because the government of Kenya was not supporting that. The harm reduction programs looked like they were controversial programs, but with the continued advocacy, sensitization, and creating of education in regards to use of harm reduction programs, I am excited on behalf of my government to say that currently the government is supporting MAT clinics. We have moved to another step whereby the community-based organizations are working very closely with the government. And we have seen a lot of success, a lot of steps moving forward in regards to provision of services. For example, I would want to give an example. The government of Kenya is currently working very closely with Kenya Red Cross Society Rehabilitation Center, which is based in one of the island. In that island, it is considered unsafe to provide any services there because most of the times we get terrorists attacking residents of that city. But since the rehabilitation center began at Lamu, we have seen it has opened access to treatment and rehabilitation for drug users. The community is aware and stigma has gone down. So we are having people accessing the rehabilitation facility in Lamu, and we are hoping that it will grow with time. We, as the government of Kenya, our responsibility at the Kenya Red Cross Rehabilitation Center was to regulate and to ensure that the national standards, which are founded on the international standards for treatment and rehabilitation for persons with substance users, are implemented. So we certify and accredit the rehabilitation facilities in Kenya, ensuring that persons with substance use disorders get quality services. I'm also glad to say that currently we have a fully fledged MAT clinic in one of the biggest prisons in Kenya, that is Shimo La Tewa. And the government has worked hand in hand with the CBOs. So the CBOs do the psychosocial support, the government provides the methadone and the counselors, and we are moving well. So the people who are discriminated against, like the prisoners with drug use problems, can now access and get the necessary support that they need. I would also want to say that we have mainstreamed gender responsive programs, that is including harm reduction. Currently, women can access MAT programs, women can access reproductive health services, and this specifically women that use drugs, because initially there was so much stigma surrounding how women could be using drugs. But currently, we are proud as a country to say we are moving forward and people are getting more informed on the need of supporting persons with substance use disorders. There's so much advocacy by the government ministries, even through the media and the radio, the local radio stations, whereby people speak and emphasize the need of supporting persons with substance use disorders. It is important for every key stakeholder to hold hands and to work together towards restoring dignity of drug users. Currently, we have programs whereby the prison wardens and the police officers are being trained on how they can come in to support persons with drug use problems, so that we don't arrest them and put them in prisons. We are treating them in a dignified manner. We realize they are sick people, and we are providing access to treatment and rehabilitation programs. So even in the issue of reporting, we have managed our data collection, because both the CBOs and the government are working together towards contributing to the National Drug Observatory, so that when we are required to report to UNODC or the AU, we have a well-compiled data which is not contradicting between the CBOs and the government. I am also glad to say that the government and the CBOs have partnered in providing telehealth services. The Kenya Red Cross Society has a toll-free number which works 24 hours. That is 24 hours providing services to persons with substance use disorders. And also NACADA, the institution I work for, which is a government agency, has a toll-free number 1192. So we are jointly providing telehealth services to all Kenyans who have substance use disorders or any other issues. To close my presentation, I would also want to say the government of Kenya has incorporated treatment and rehabilitation of substance use disorders in the National Health Insurance Fund. So I am so proud, I am happy. Persons with substance use disorders can access free treatment in accredited facilities by the government. I am happy, and I also agree with my former panelists that we need to put our hands together, our efforts together, to ensure that drug users are treated with dignity and they can access the services they need. Thank you very much. Over to Dr. Massimo.
Thank you very much, Judith. Concerning your mention of the role of police, the best person that can speak about this is the next speaker, Jacques Charlier. So, Jacques, I give you the floor.
Good. Thank you, Dr. Barra, and good morning, good afternoon, good evening to everybody. My name is Jacques Charlier. I'm the Executive Director of the Police Treatment and Community Collaborative, which is the national voice of the globally emerging field of deflection and pre-arrest diversion. The title of today's CND panel is Moving Beyond the Division in Order to Implement Humanitarian Drug Policies. Now, for those in the clinical or treatment world or in recovery, this title can probably be readily understood. But from a criminal justice or a justice standpoint, what does moving beyond the division mean? What is this divide of which this panel of Rome Consensus 2 is speaking to? How does it apply to the world, to those of us who, like me, so those of you who are here today who are working in your nation's justice system, how does this apply to those of us who, like me, work as part of a nation's justice system to reduce crime, to keep people safe in their homes and communities, and to stop people from suffering the pain and trauma when someone becomes a victim of a crime, which includes people who use drugs themselves, who also are victims of crime? Well, as it turns out, here too, in this space where police and law enforcement, as well as other justice professionals who are with us today, judges, wardens, prosecutors, defense attorneys, work day in and day out, there is a division for us to move beyond in order to achieve the goal of the Rome Consensus 2, a humanitarian drug policy. And that division is simply this: the use of alternatives to incarceration, such as deflection to drug treatment, as a successful crime reduction strategy on one side of this unbridged divide, versus arrest, conviction, and incarceration as a successful crime reduction strategy on the other side of this unbridged divide in our world of justice. Now, from the standpoint of all of us who, as I said, like me, work in criminal justice or in justice, it would be correct to say that if arrest, conviction, and incarceration would reduce drug crime and drug use and help people get well, then by all means, we should continue to do it. That would be correct. That would be logical. But there is a simple problem to this approach on that side of the divide, and that is this. For the most part, arrest, conviction, and imprisonment for drug use doesn't and can't, and indeed, it does quite the opposite at times than make us safer and make our communities safer in the nations in which you live. It can instead, arrest, conviction, and imprisonment for drug use worsen drug use, and that means more activities and behaviors related to drug use, which means more crime, which means more victims of crime. Indeed, and to be very clear, the now long-standing evaluation and research done across the globe continues to show that when people get into drug treatment and recovery, they get better. And when they get better, they stop doing the things that go with drug use. Actions and behaviors related to seeking drugs that cause harm and injury to others to satisfy the demands that untreated drug use places on them. And we know for people who enter our nation's justice systems, the issue of drug use is even much larger and much more pronounced than it is for the general populations of our nations. Note that this divide, for those of us who work in the field of justice, is a conversation about reducing crime, about reducing number of crime victims. So I offer that for my colleagues and I who work in justice and for justice and care deeply about justice being done, simply this: if a humanitarian approach to drug policy, as envisioned and as stated by Rome Consensus II, can break or interrupt the cycle of drugs and crime that we all want to see broken and interrupted, and leads to less people becoming victims of crime, why would we not do it? In other words, if we can have less victims of crime due to reducing the actions and behaviors that result from people who use drugs untreated, would we not want to work towards that and get on the side of our justice divide in our field of justice that instead reduces crime, that makes us safer and makes our neighbors and our families and our children better? The answer to that in many languages is yes. The answer is sí. The answer is ja. The answer is endil. The answer is da. The answer is yeah. And the answer is we. As a person who has devoted his life to reducing crime, which is to say, reducing the number of people who have to go through the pain, hurt, and trauma that comes when a person becomes a victim of crime, including people who use drugs, then for me, that is the grounding and the central issue. So I ask you, those of you here who are justice professionals, to lead the change in your justice system following the principles of Rome Consensus II. Indeed, as justice leaders, which you are, if you are here with us today, as I've said, we must, indeed are bound to, move from a professional, ethical, and intellectual integrity standpoint towards a humanitarian drug policy as conceived by Rome Consensus II and Dr. Barra's leadership and the leadership of all those you have heard and will hear today, which is to say, towards leading your justice system towards a drug policy that overcomes this divide of the past in our work and looks instead to a united humanitarian future that will keep people safe by first keeping people well. And in cases then when we as police or prosecutors or judges deal with people who use drugs, that alternatives to incarceration, such as deflection to drug treatment, housing, and services, is the norm in your nation's justice leader, thanks to your actions following today's panel, following the guidance of Rome Consensus II, from here and forevermore, to build your nation's more just justice system. Thank you for being with us today. We look forward to working with you tomorrow and the day after and the week after as you go back to your justice system and lead the change towards a humanitarian drug policy, which is to say, towards a policy that promotes reduction in crime and reduction in crime victims. Thank you. Dr. Barr, back to you.
Thank you. Thank you very much, Jacques. You are really a pioneer, an inspiring pioneer. And your words are very important for all of us. Before giving the floor to our last speaker, I want to say bye-bye to Rick Olstrom, that is listening to this meeting without speaking, but it has been fundamental for all the project, the birth of Rome Consensus, point 2, fundamental. Thank you, Rick. And now I give the floor to Raquel Peyrov, a doctor from Uruguay. I give you the floor, Raquel.
Hello, good morning. Thank you, Massimo. Thank you, Rome Consensus, for having me here. I'm today represented Knowmad Institute, and I'm very glad, you know, I'm a sort of real dinosaur in this story. I've started in the 80s, so it's very nice, it's very touching, realizing that many changes are happening around the world. However, it's not the global reality. And I'm not going to repeat what has been said thousands of times and about the scandalous failures of prohibitionism. You know, to talk about harm reduction is to stop prohibitionism, because if not, you cannot approach these people the way they need. So every year, civil society and academic organizations have presented data that confirm the failure of the war on drugs and prohibitionism. And also, governmental delegations of countries have publicly acknowledged the suffering of their people due to the ineffectiveness of current policies and devastating impact of the war on drugs. And Latin America is a particular example of that. This involves 620 million people. It's a lot. On the other hand, in an explicit or silent way, there is also great disappointment about the results of the hegemonic preventive and treatment strategies aimed at creating a world without drugs, a drug-free world. Despite the generous time granted to prove their effectiveness, they have not kept their promises. On the contrary, the general picture is worse. Also, a strong and almost exclusive bias, except these exceptions we have seen today here, bias towards abstention as treatment goal persists globally. And it's actually difficult to understand why, except if we assume that countries are waiting for a CMD formal legitimation of harm reduction, at least to explore this possibility, these strategies. Specialists in the drug field, including myself, support the idea that comprehensive drug policy must include supply reduction, demand reduction, and harm reduction, plus risk management. This is not prohibitionism. We know from the health perspective that the last two, harm reduction and risk management, are the strategies that serve the majority of people who use drugs, because only 10% at any time, only 10% of them are prepared to quit using drugs. People who use drugs, the general population and states are trapped in a corridor that represents the tension between drug conventions and the inability of countries to move towards policies that account for the reality of the problem. Although discussions usually revolve around two blocks on drug policies based on their different position with respect to cannabis legalization and flexibilization of some measures, in reality, there are just two versions of the same prohibitionist model, with nuances in terms of their potential for explicit cruelty. There is no breakthrough. There is no improvement in the figures, global figures of prevalence, illness, and death. The UN, ODC, and CND should help us, just like Giovanna have been showing us, to solve this tension and promote progress towards more realistic, effective, and humanitarian policies. It is imperative today that just as in the late 80s, when the WHO enabled countries to incorporate harm reduction, the United Nations now send a message of approval of these public health interventions so that they are included systematically and not as exceptions or NGOs' approaches as a fundamental pillar of drug policies. The United Nations also should remind governments that human rights conventions are mandatory and hierarchically superior to drug conventions. Let's respect them. Isn't the health and life of all people a human right? Or is that human rights that not apply to people who use drugs? In Latin America, this is very, very frequent. It is not possible to continue year after year raising the same questions and almost begging to empathize with people who use drugs and to be heard about the reality of the global situation. Let's face it, many governments will not move towards more ethical and effective policies unless there is a clear message from United Nations drug agencies, as clear and loud as that of the failed war on drugs. We understand and actively promoting harm reduction to improve the quality of life and survival of people who use drugs is a call for humanitarian ethic, but also a matter of political responsibility. United Nations agencies competent in the matter must change the message strongly. We have no more time to continue debating, thinking about and tolerating human rights violations. We don't want to continue investing energies in coming here and having no significant global changes. Let's learn from these experiences that my colleagues have been presenting. And this time for the changes are just now. So thank you so much for your attention. It is a very touching moment for Latin American people.
Thank you, Raquel, for your passion and your speech. And now we are a little bit late, so I quickly give the floor to Lascia, Dr. Lascia Gogwadze, our colleague in Geneva at the International Federation, for the last part of our side event. Lascia, you have the floor.
Thank you very much, Dr. Bara, and thank you all the speakers. So before we move to the last part of the session, I would like to thank CEO Recovery Foundation, here represented by the CEO, Mr. Jack O'Donnell. Thanks to C4 Recovery Foundation team who worked behind the scene to organize this virtual side event that is joined more than 200 people, I think. So and this is really the outstanding outcome. So let's move now to the next session, questions and answer session. So we have now, I would like to give the floor to 𝗔𝗓𝗓. 𝗔𝗓𝗓 is a social worker from Villa Manani Foundation. So 𝗔𝗓𝗓, if you are connected, so can you share your experience and put your question if you have any? 𝗔𝗓𝗓?
He is online.
Yes. Yes. Can you hear me?
Yes, clear.
Yes, go on.
Okay, thank you, Mr. Lascia. First of all, I would like to thank you for this opportunity. It's my first time that I was given so important chance to give my testimony in this very important event. Okay. To start with, I would like to give my little story and testimony. I was born in Rwanda. Now I'm speaking from Rome, Italy. My story started like this. I was very young when I started, when my mother saw the possibility of the ethnicity conflict in Rwanda. So she just, I'm on the air. No,
Yes, you are going.
Yeah, what I'm saying, I was very young when my mother noticed that there is a possibility of ethnicity conflict in Rwanda. So she escaped to a nearby country, which is Tanzania, and which is where I grew up. In Tanzania, in order to go to school, my mother set up for me an adoption family. And to make story short, I received all the kind of abuse in that house, which lead me to escape and start street life. And my story didn't end up there. So I started living street life. At the same time, I saw the importance for me to become a man instead of living my childhood, and in order to support my mother and my little sister, which they were alone. I went on like that until it reached a time many years after I find myself in Italy, where I was also living street life. I was dealing with drugs. At the same time, I started to be consumer of my products. And I was really deep into it until I reached to the stage that I was tired. But at the same time, I had no one to turn, for help. There, I came to with contact with 𝗍𝐵𝐴𝐸𝐸 Foundation. I started to take methadone in 𝗍𝐵𝐴𝐸𝐸 for some time, but at the same time, it didn't last long because police were, I was wanted and then I was arrested. When I reached prison there, I made up my mind and say, yes, this is the time that I have to quit and start a new life. I'm tired of what I was living for. And then in prison, I came in contact again with the volunteer, 𝗍𝐵𝐴𝐸𝐸 group, psychological group, which we are doing now in prison. So I start to follow their groups and I continue until they give me chance to go to their alternative, 𝗍𝐵𝐴𝐸𝐸 Alternative Center for the Detention, to finish my sentence, of which I finished my sentence and did my rehabilitation programs. At the same time, 𝗍𝐵𝐴𝐸𝐸 helped me to continue with my study until I obtained many qualifications. Among them is including social operator, intermediate cultural, and social work as well. So at that point, 2 years ago, 𝗍𝐵𝐴𝐸𝐸 decided to hire me as one of their workers, and now we are working together to help those who are passing the same situation that I was in. And to me, really, it is a passion. It's not only work, it's something that it became like a passion. It's, I do it not in a way that someone can say that I want to reach the end of the month, but it is a part of me. I'm trying to use my experience, to inspire and empower those who are still living in the same situation which I was. So for that, I really appreciate it. Thank you, 𝗍𝐵𝐴𝐸𝐸. The only question that I would like to pose in this is I believe that moving beyond the division in order to develop humanitarian drug policy is very important for me as title. But how difficult it is to apply the humanitarian drug policy globally. I can close with that if you allow me. I don't know if I'm...
Thank you so much, Oji. So thank you for your work and for your commitment. So this is one of the top important issues. We noted your question, and then so we will address the panelists to share their opinion about it. So the next intervention. Hello. The next intervention we will have from Mexico, Oscar Garcia. Oscar, floor is yours now if you are connected. Oscar?
Good
Yes.
morning.
Good morning.
Good morning, Mrs. Lasha Lozade, organizing committee and people who attend this side event. I'm Oscar Espin, a researcher in Knowmad Institute. So in representation of Knowmad Institute, I take the time of my request to release the discussion paper called Stigma and Discrimination Related to Substance Abuse. So I want to share my screen. So why we interested in this topic? Because worldwide about 35 million people suffer substance use disorder and only 1 in 7 receive treatment. That was stigma and discrimination is one of the major barriers to the care in the field of drug abuse. So in the discussion paper, we work theoretical concepts to understand the difference between prejudice, stigma, and discrimination. And we make a review of the literature to understand stigmatized attitudes and discriminatory practices to people who use drugs, such exclusion, rejection, physical or verbal abuse, and gender violence. So based in the UNODC meeting, Exclusion, Not Exclusion in 2020 year, we propose some strategies for fighting stigma and discrimination. And well, to get a better comprehension, we launched an online questionnaire in February of this year and analyzed some answers to make reflections about stigma and discrimination against people who use drugs. Finally, we discussed the findings and proposed some recommendations to reduce stigma and discrimination toward people who use drugs in the communities. So for ending my request, I only want to say for Knowmad Institute, we are pleased to be part of Brown Consensus Group, and we want to thank the founders, especially the valuable work of the contributions of the Dr. Massimo Barra. Thank you for your time.
Thank you, Oscar, and thank you for sharing your document. This is very important. The next intervention and question we will hear for Kamrin Rigby. Kamrin, please, you have the floor. Kamrin?
But hello, I would like to thank Dr. Barra and Rome Consensus for allowing me to be here today. My name is Cameron Rigby.
Yes, we hear you. We hear you. You have 1 minute for your question. Yes.
Utah State in the United States. I would like to address this question to Mr. Jacques Charlier from the PTACC. As we all know, from 1999 to 2019, nearly 500,000 people died from an opioid overdose, including prescription and illicit opioids in the United States. These numbers increased significantly during the 2020 pandemic, and this rise in opioid-related overdose deaths is shocking. I know the CDC is committed to fighting the opioid overdose epidemic and supporting states and communities as they continue to work to identify outbreaks, collect data, and respond to overdoses. And they provide care to those in their communities. I also know that there are many organizations like the ones who are promoting the Rome Consensus today. But I was wondering how the academic world, including faculty members, researchers, and college students, can effectively advocate for a more humanitarian drug policy, especially students studying human rights, global studies, and criminal justice. Thank you.
Thank you for your question. Jacques, question was for you, so maybe you could respond to this question.
That sounds good. I will do that quickly. Cameron, thank you so much for the question. So how can universities or educations of institution help us move towards a more humanitarian drug policy? I will answer that very quickly, as I said, Cameron, from the standpoint of someone who works in the arena of criminal justice. First thing, universities are educational institutions. So one of the most critical activities that universities can do is within their nation. So all of you on this panel, a call to action if you are in the academic field, go find your local, regional, and national justice leaders, your judges, your prosecutors, your law enforcement leaders, those who lead your prisons, and educate them on the neuroscience of addiction, educate them on recovery, educate them on alternatives to incarceration. They might just not know it. And you as a university, whether you're students or faculty, both in the arenas of drug policy, in the arenas of criminal justice, in the arenas of medicine and science, can help justice leaders become educated. They just might not know how it is that drugs affect the brain and that addiction is a relapsing disease, a chronic relapsing disease of the brain. So that's the first thing, directly educating your local and national justice leaders on the neuroscience of addiction and why treatment works and why recovery matters from a scientific standpoint. The second thing, very quickly, and then I'll stop, is universities, again, as educational institutions, create cadres of people who go into fields, is to create a cadre of justice leaders for your nation, for your communities in which the universities operate, that know and understand how to work at the intersection of justice and health, the intersection of justice and health, develop curriculums and programs that understand and lead to those connections, health and justice together, science, evidence-based, and research, not just a criminal justice program and not just a health program, but a health and justice program, degrees and certificates for people in academic institutions, for those in the work world who want to return and get a certificate or another degree in integrated justice and health. So that's my answer. And Cameron, thank you again for the question and for being at today's panel.
Thank you very much, Jacques. So I just want to pose the question to the panelists, and this is basically the OJ's question, and it concerns so how we can make the Rome consensus practically applied in a different context and in different countries. So maybe we can start with Raquel. What do you think, Raquel? How can we apply the consensus, the policy, into the practice?
Well, I think that there is an important lobby work to do, advocating for this, start working with governments. You know, we need in Latin America, start a discussion, because as I said in my presentation, governments are waiting for a permit. Uruguay hasn't done that. You know, we have legalized for full all the purposes, and we are not asking for permission. We are doing what we have to do. But this is not so real for treatment, for harm reduction. The prohibitionism is there waiting for us to fail. So we need organizations and declaration, just last Rome consensus, to start discussing, advocating with governments. Governments are very important to set up the policy, the harm reduction policy, as a pillar of a comprehensive policy. So I think that Rome consensus has to start working more closer to the governments in Latin America. But not only, because we know that in Europe also many programs that were fantastic in the past, safe room, injection, prescribing, are shut down by many governments, UK, for example. So it's not only a problem in Latin America and Asia, it's a global program. Prohibitionism is pushing ahead, and we have to work with that.
Thank you very much, Raquel. And having the opportunity that we have Judith here, representative of the national authorities. So maybe Judith, you can reflect to this question. maybe you can tell us something. So how can we promote further, and how can we use the already existing progress that we made, for instance, in Europe related to the decriminalization? So how the European countries can be champions to promote the worldwide, and how the Rome Consensus could contribute.
You will never drag me to comment on any region and any single country, my dear, but I think I want to start from build on what Raquel said. And it's the need to advocate towards the government. Governments may not know, like Jack was saying, government official may be very fearful of public opinion. And the fact of the matter is that the stigma associated with drug use disorders means that people don't feel like, putting a lot of resources towards this kind of population. And that's why we need to join forces. And I know that there are lots of different points of view, even within civil society. But if civil society connects and a lobby with one voice, and we connect together, I mean, we try to, bring ideas from the other point of view, science and academia, like Jack and apologies for the last speaker, I forgot her name, I'm really sorry. But as she was mentioning in terms of what students can do, it's a matter of coordinating that advocacy and really bring forward the view that people who use drugs, people with drug use disorders, have a right to health, and meeting that right to health is, by the way, productive and with good consequences for everyone, so that politicians can see also that, how can I say, self-interest there, which never harms.
Thank you, Joanna. I don't want really to miss anyone's question, important question. So there is one question. So how the harm reduction centers are considered from the social point of view in different countries? So maybe, I don't know who can respond to this question. Maybe Massimo, maybe you could respond to this question.
I think that the more people understand what is the philosophy of harm reduction. It is not free drugs. It is not favorizing the use of drugs. It's avoiding a point of no return. First of all, you cannot treat a person who died for overdose. This is the basis of any kind of treatment. First, survive. First, avoid the point of no return. The success in terms of prevention of disease are incredible. When I was young, in Rome, the 80% of people was positive to hepatitis C. We did not discuss about HIV because we did not know HIV. But when we started giving the clean needle, it was for the hepatitis. Now from 80%, we are at 15%, 20%, an incredible success, incredible. So harm reduction works, as it has been said by the representative in plenary of UNAIDS. Harm reduction works. Harm reduction saves lives. I think that if people understand this, we can develop further and prevent a lot of people death.
Okay. Very clear.
I would add,
yes,
I would like to add something, maybe. Thank you, Lasha. I think that from the social perspective, what is asked by the attendee, I think that harm reduction is includes psychosocial approaches, and many of the interventions are from the social perspective. We are not always only working with needle syringe exchange or prescription. We are also working in drop-ins, what means that people are having a shower, meals, where to stay, helping them to get their ID, for example. There are many measures that include the basic social interventions, and psychosocial interventions in harm reduction are the tool for education. Educating people in harm reduction, people who must be educated in what harm reduction means. And this is a psychosocial intervention. Thank you.
Thank you very much, Raquel. So, basically, time is running, and unfortunately, so we need to close the session. So we will collect all the questions, and if we have the colleagues attendees emails, we can respond. So it was a pleasure to see such a large number of people who registered, and the large number of people who stayed now until the end of the session, because we are quite late. So we had the representatives from the Red Cross, Red Crescent movement, UN agencies, from government, from NGOs, from the communities. And basically this is the added value of the Red Cross and Red Crescent, to put together the public authorities, civil society, community organizations at the same table and work together to improve life of people. So in the invitation, you have the link to the Rome Consensus, and please read and sign and spread it. So with this word, I would like to thank all panelists and all participants and all colleagues who supported to organize this important session. So have a nice morning, day, or evening. Thank you, everyone.